Hi everyone, my name is Esmita Charani and I am a research pharmacist and a research lead at the NIHR-funded Health Protection Research Unit in Healthcare-Associated Infections and Antimicrobial Resistance at Imperial College London. I also have faculty positions at the University of Cape Town in South Africa and Amrita Institute of Medical Sciences in Cochin, India, where I am collaborating with colleagues into investigating how we can better implement antimicrobial stewardship interventions in the hospital setting. This is a really key question, and it's really important to realize that although there are expertise and experts involved in the diagnosis and management of infections, by the ubiquitous nature of infections in the hospital settings, all healthcare professionals and healthcare workers do get involved in infection-related care for patients. Therefore, in terms of antimicrobial stewardship, if we are to make differences and progress in implementing effective change in behaviors and attitudes towards how we use antibiotics, we need to engage with the multitude of healthcare workers that are operating in healthcare settings. Of course, we need a core team of antimicrobial stewardship expertise. This includes a multidisciplinary team that has to have pharmacists, microbiologists, infectious diseases doctors, and infection prevention and control expertise, because infection prevention and control and antimicrobial stewardship are integrated and go hand in hand. However, it is important that this team then engages with the wider healthcare workforce to ensure that we are able to change behaviors and attitudes. And of course, within the wider One Health perspective, we also have to include expertise from community. So we have general practitioners, we have community pharmacies, and we need to develop mechanisms for all and strategies for also involve patients and the public and civil society in this drive to optimize antibiotic use, because across different cultures and societies, the many different factors influence attitudes towards antibiotic prescribing. In the NHS, we have a lot of funding that has been dedicated over the last 20 years to implement stewardship interventions in hospitals, recognizing the need to have pharmacists, developing specific roles, directors of infection prevention and control, that are responsible for ensuring the delivery to the objectives of antimicrobial stewardship programs. And also, this is all, the MDT approach is now well established in guidelines and policies, both internationally and nationally through the World Health Organization Global Action Plan for Antimicrobial Resistance and the national action plans that individual countries have implemented. Communication is really important as part of how we work together in healthcare settings. And in terms of antimicrobial stewardship, it is essential. And it is important to set agreed to and co-developed and co-designed policies and guidelines that underline the expectations about how we are to treat, manage, diagnose and treat infections in the hospital setting. This requires an organizational vision and strategy, and there are many guidelines and policies now available to assist organizations to be able to develop effective communication strategies for antimicrobial stewardship. There has to be leadership. Leadership is really key to any team, particularly in the clinical setting. We've done a lot of research that demonstrates that medical practice and healthcare workers work within very territorial, tribal almost cultures, and it's really important that we engage with leaders within different specialties, within different teams, to have buy-in for the interventions that we want to implement as part of antimicrobial stewardship programs. This means tapping into leadership and identifying champions and role models that can take forward the initiatives that we want to implement. And I mean, we have a lot of research that supports this, but antibiotic prescribing is a social process. There are many different healthcare workers involved, as I mentioned earlier. So it is important that we develop a communication strategy that recognizes the risks that different healthcare groups and different healthcare workers attribute to patient outcomes and what it is that they recognize as optimal outcomes for their patient groups. It isn't often that antibiotic resistance. We have to understand how we can translate the impact of AMR on different patient populations and what it means to different healthcare workers and how they will measure this and how they will measure optimized outcomes for their patients. That's when we can develop an effective strategy to be able to change people's minds and attitudes towards how we use antibiotics more effectively. And the hospital leadership is also extremely important in this, having a sustained mechanism for engaging within the leadership within the organizational structure to support the strategies that we want to implement are key for success. I talked about the cultures within organizations, and what we have to also recognize is across different countries and different parts of the world, there are different stakeholders involved in antimicrobial stewardship. Whilst we talk about the role of pharmacists, in many parts of the world, pharmacists aren't still recognized as being part of teams. So we have a lot of inroads to make in how we change attitudes and cultures globally. And this can be done by best practice, by showing how it is done successfully in different parts of the world and how we can, or even within organizations within different countries. So, for example, we work with a hospital in India where they have been championing the role of pharmacists in antimicrobial stewardship. And this is something that now they are teaching and they are using as best practice to enable others to overcome the barriers and the cultural sort of obstacles to implementing optimized antimicrobial stewardship programs that is multidisciplinary. Nurses are another group that need to be far more involved and given a platform to be involved in antimicrobial stewardship. And again, this is a cultural barrier that we need to overcome through training, through education, through providing support and giving a platform for people to be involved. And from our experience, the best way to do this is to collaborate in equitable partnerships for research and implementation, but also to have a plan to develop strategies that are contextually appropriate. Monitoring is essential. Surveillance and measuring what we're actually doing is essential for us to be able to change practices. So we have to identify mechanisms where we can collect data on our practice around antibiotic use and the prevalence of infections from different settings so that we can compare and benchmark behaviors across different cultures and different countries and different organizations. And we still have a lot of improvements to make in that field. And once we have this data, we can then adjust our behaviors and find a way to be able to optimize practice. Now, the World Health Organization has produced guidelines and policies on this, which are helpful for different countries in different contexts. But what it comes down to is people working together more cohesively in partnerships that are equitable and that recognize the resource constraints in different settings and how we can develop minimum expectations for best practice across different resources. So this goes back to what I was discussing in the previous point that was raised. It is really important for us to realize that antimicrobial resistance and the threat of AMR do not recognize cultural or geographical boundaries. And so we need to work much more collaboratively through a One Health approach that takes into consideration not only how we optimize antimicrobial use in human populations, but also across the environment and in farming and fisheries. And this requires a holistic approach that brings in policymakers, brings in politicians, because unless we engage with policymakers and politicians, we will not be able to release the funds that are required to address the economic limitations in different settings and for us to be able to have access to all the resources we need to implement effective antimicrobial stewardship. There also needs to be greater collaboration and equitable collaboration around the research so that the movement of funding and knowledge and expertise isn't just from the global north to the global south, but that there is more equitable balance in how we share knowledge, how we create knowledge around the challenges of AMR and to address it, particularly in low and middle income settings where the burden of infectious diseases is highest and the stakes are highest. To that end, one of the key factors that we need to consider is access to effective antimicrobials that are safe, that are quality assured, and that are regulated. These are still challenges we face, and we need a lot of research and collaboration across different countries to be able to develop strategies to make sure that those who need antibiotics have safe and affordable access to them, but that at the same time we are regulating so that the use of antibiotics so that they are only used when they are needed. And for this, we need greater organization as globally for us to be able to work with international agencies, with governments, with academia, and with healthcare stakeholders to make sure that we are implementing interventions that are contextually fit for different contexts, but also that they are equitable and that they create opportunities for access to medicines to those people who need them whilst regulating their effective use. Because it is really important, something that I always mention is the threat of AMR is very big. However, there are still more people dying from the lack of access to effective antibiotics than from the threat of AMR. And that's something that needs to also be considered when we talk about antibiotic resistance.
Welcome to everybody. My name is Antoni Torres. I am professor of pulmonology and critical care at University of Barcelona, Hospital Clinic in Barcelona, and my area of interest and research are respiratory infections. Well, initially you have to look at the clinical signs and symptoms. There are some of them that will allow you to suspect an infection. For example, fever, for example, confusion, and abnormalities in the vital signs, including tachycardia and respiratory rate. Then you have to check the hematological and biochemical parameters, for example, leukocytosis, lymphopenia, and in the case of biomarkers, an increased CRP or an increase of procalcitonin. The second step is to look at the rapid stains that you can check in these samples. For example, the Gram stain or the stains for fungi and other stains. In the case of urine analysis, you have to look at the presence of leukocyte esterase. Another important point is that now we have available new molecular techniques alone or in panels that will give you a very sensitive determination of microorganisms. In case of bacteria, there are some panels that include several bacteria and a sum of the most important microorganisms of resistance, and then this will allow probably to start an adequate initial antibiotic therapy. The first criterion is to know the particularities of the patient, including comorbidities and immunosuppression. The second one is to consider the local resistant patterns. This is very important because if the incidence in the unit or in the ward, in the hospital of MDR, XDR microorganisms with a particular mechanism of resistance is going to be important, then you have to consider drug interactions to avoid these interactions, and very importantly, the dialysis of the patient, the body weight, and the renal function for dosification. After that, you have to consider national or local guidelines better, and you have to follow up these guidelines, and the algorithm is recommended. But guidelines are not for all patients. There are exceptions, and then you have to really look at very carefully the recent antimicrobial use to avoid repetition of the same antibiotic, recent travel abroad for particular resistances, previous colonization of multidrug-resistant infections in the feces or in the respiratory secretions, and finally recent hospital admission, because this is clearly a risk factor for MDR, XDR, gram-positive or gram-negative infections. This question is not easy to be answered, but there are some rules that you have to follow up. You have to keep in mind that inadequate empirical antibiotic therapy is associated with poor patient outcomes, and then you have to ensure adequacy and early treatment. So early treatment is another point. If you start late because for several reasons, this is in relation with poor outcome, especially in patients with septic shock. About the length of the antimicrobial course, usually now we recommend between 7 to 10 days, no more than that. If less, better. But then you have to take into account some particularities of each patient that may need the patient a longer courses, for example, in case of empyema, in case of abscess, and in case of bacteremia. The escalation of empirical antibiotic therapy, according to the microbiological results, is very important, and you have to move for, if you start with combination, to monotherapy if possible. But you have again to take into account the particularities of the patient and the particularities of and severity of the infection. And the escalation is a strategy that is really considered by a strategy that is going to be beneficial in the future to prevent antimicrobial resistance. Well, after starting initial antibiotic treatment, you have to review the patients and to check several things, especially clinically at 48, 72 hours. And it depends of each infection what you have to follow up, but usually the fever, the inflammatory markers, and in case of respiratory infections, the oxygenation of the patients. Now is very well established that treatment failure or early treatment failure can be very well established at 48, 72 hours. And then if there is a failure, you have to think about an inadequate initial antibiotic treatment. You have to review the cultures. For example, a cause is the existence of resistant and unusual microorganisms. And you have to think about as well in non-infectious causes responsible for treatment failure. And these include the severity of the disease, the presence of comorbidities, microorganisms involved, and what type of antimicrobial treatment was implemented. Very importantly, in my opinion, is to assess as well microbiological determinations at day 3. So it is advisable to repeat that. In all the cases, for example, in respiratory infections, if the sample taken at day 3, the initial microorganism has disappeared or the counts are lower compared to the beginning, this is a good sign. If the counts are the same or there is a new microorganism, this is something that is not good and can be the cause of failure. If the patient is doing well at 72 hours, you can adjust or decrease the broad antibiotic therapy and go from combination to monotherapy.
My name is Ignacio Martin-Loeches. I am a consultant in intensive care medicine in St. James's Hospital in Dublin, Ireland, and a professor in medicine in Trinity College, also in Dublin, Ireland. My main area of interest is infections in critically ill patients, and I'm here today to discuss with you about some topics for multidrug-resistant pathogens and alternatives of treatment and diagnosis, and I'm very, very happy to be here with you all. This is a very important question because when we are talking about multidrug-resistant pathogens or extensive drug-resistant pathogens is becoming a real threat in our hospital settings in general and in ICU in particular. The main reason is because we have more and more often more vulnerable populations, and we have seen that these patients, they might develop multi-drug-resistant infections. These infections are going to be linked with high rates of mortality. But I would say that even more important than the mortality itself is that there is a very increased healthcare cost with increasing the length of a stay, increasing resources, and we have the constraint of ICU beds in many places in the world. So the beds are not infinite, so we need to deal with these infections. It is important also not to only talk about multi-drug-resistant pathogens in terms of infection, but also in terms of prevention. And probably the most important point is appropriate treatment. However, we need to also incorporate in current practice that we call antibiotic stewardship programs. So, which is the way that we are going to integrate into clinical practice how to use wisely antibiotics. And there are at the same time a good number of worldwide initiatives to develop new drugs in order to treat multi-drug-resistant bacteria in the last decade. However, they are maybe not enough, and we need for sure more investment and more development in this particular area. Well, for sure, we have seen that there is a good number of new antibiotics that they have been launched in the last few years. That they have been mainly beta-lactams, and the current question is how we are going to implement non-beta-lactams inhibitor drugs in the current practice. And this has been something that we have seen for the last years. We have seen that we have drugs such as aminoglycosides that they have been used in ICU. However, we have seen some discrepancy with what we call the clinical efficacy and how they work in the lab. So this is something that we are looking forward to having more agents that they are going to help. I'm going just to give 4 examples of new drugs. One is plasomycin. Plasomycin is a drug that has been approved for UTI and acute pyelonephritis. I think that this is a very interesting drug for this particular type of patients. However, we might need to see how they work in what we call hospital-acquired pneumonia or even ventilator-associated pneumonia. Another drug of interest is eravacycline. Eravacycline is a drug that is also helping not only in UTIs, but also in intra-abdominal infections. There are some studies comparing with ertapenem and meropenem for the former and to levofloxacin for the later. And there has been no inferior treatment compared to ertapenem, but did not meet non-inferior criteria compared to levofloxacin for complicated UTIs. Muripavadin is a very interesting drug because it's going to be a drug that is going to be interested for Pseudomonas infection as a monoclonal kind of antibiotic. And there are some studies with inhaled treatment in cystic fibrosis. And an old drug that is back to the current treatment is colistin. Colistin has been always a drug with many controversies because of the nephrotoxicity. Sometimes the problem is that this is the only drug that we can use for multi-drug-resistant pathogens, and we are as well using, but definitely this is a very interesting point, how to develop new drugs that they are not in the beta-lactam world. I think that probably this is a key point in the current critical practice. This is what we are now using. I think that we are lucky to have many drugs being developed in the last few years. And again, we are lucky to have them because in patients that they are in ICU, we have seen a good number of patients that they had multidrug-resistant resistant issues in ICU. So especially in COVID, we have seen a huge number of patients with ventilator-associated pneumonia with either ESBL, AMSs, CRE, and thanks to some of these drugs, we have had opportunities. So trying to summarize for complicated UTIs, there are some beta-lactam inhibitors, such as imipenem, relabactam, meropenem, barbobactam, or ceftazidime avibactam. These drugs have been used, luckily, in patients with CRE. We have also the opportunity to count on ceftolozane tazobactam for patients that they have multi-resistant Pseudomonas. For intra-abdominal infections, again, we have the opportunity to use ceftazidime avibactam and imipenem relabactam. However, I think that is very, very important to highlight that in both infections, abdominal infections and UTIs, we need an adequate source control. And another area of interest is, as I mentioned before, hospital-acquired infections. We have seen many of these infections, and in many occasions, we haven't had the opportunity to treat them with adequate treatment. And this is the reason that we have some new drugs, such as ceftolozane tazobactam, that is targeting very nicely against Pseudomonas aeruginosa, ceftazidime avibactam, especially useful for gram-negative agents, especially ESBL and CREs, and imipenem relabactam with the launch of the Restore IMI-1 and Restore IMI-2 trials. There are some other combinations that they are coming into the market, like Aftrion avibactam and meropenem ecubactam, that they are going to provide other alternatives for Enterobacterales and Pseudomonas, that they are increasing resistance worldwide, and they are usually associated with high mortality rates. Well, I could say that this is kind of the $1 million question, or euro or pounds, but the thing is, I think that we need to understand really well surveillance. I think that the local epidemiology is the major aspect in the treatment of patients that they are in critical care settings. Another important matter has been a huge development of new agents in order to broaden the spectrum of what we have at the moment in ICU. However, I don't think that we have seen the same development in some diagnosis. I think that we are still waiting kind of a lot for getting results. This is the reason that we need more molecular testing. There are some in the market, but I think that there is a kind of a slow acceptance into clinical practice in order to decrease the time. These new methods of molecular testing and other methodologies are going to improve the speed of diagnosis, and they are going to decrease antibiotic treatment in order to both start with the wrong agent, and second, to de-escalate easily. So I think that this is an area that, in my opinion, we need to develop more. I think that we are lucky to have new agents, but at the same time, we don't want to get them resistant very quickly. And for that reason, we need to avoid the undiscriminated use of these agents. And the only way to use them wisely is targeting the right patient with adequate therapeutic requirements, and probably using better molecular testing in order to implement what is the most important at the end, the clinical outcome of the patients, that is survival and length of stay.